Great.
Welcome everybody to our Architecture for Health visiting lecture series. My name is George Mann. We have a group of distinguished speakers and people in the audience. I'd like to welcome Ron Skaggs, who's one of the sponsors of the lecture series. And now I'd like to turn this over to Patrick Suermann, who is the head of the Department of Construction Science. And I just asked Patrick how many students are in that program. There are 1,173 students, and they're in high demand, and it's the largest department in our College of Architecture. So Patrick, I'd like to welcome you and thank you for your collaboration on this lecture series.
Well, I really appreciate that, Professor Mann, and I'm excited to introduce our three speakers today. First, I wanted to ask if someone was going to be sharing the slides concurrently while I was doing the introductions, because I think there's an intro slide on there.
So, yes, thank you.
Okay.
Yeah.
I think I'll start with ladies first, if that's okay. So Ann Garrity is a lead AP. She's a senior planner and interior designer with Tsoi Kobus Design. She's trained in both architecture and clinical psychology. Ann possesses a unique understanding of how people interact with their environments. She leads the planning, programming, and interior design process, including early client workshops and visioning sessions. Ann holds a Master of Arts in Environmental Design from the New England School of Art and Design and a Bachelor of Art from the University of Maryland. Ann is a LEED accredited professional, and she holds a Lean in Healthcare certification from the Massachusetts Health and Hospital Association and GBMP. Ann recently led a highly successful visioning, planning, and programming process for a new comprehensive cancer center for the Order of St. Francis Healthcare, focused on lean planning principles and a collaborative care concept centered upon holistic themes of wellness and prevention. Moving to your right there, Dr. James McGee. Dr. James McGee grew up in central Illinois on a farm his grandfather homesteaded in the 1880s. He manages that farm to this day and maintains the property as it was in the 1900s. He was educated in local schools and studied piano performance at Millikan University through high school. After attending the Franciscan Quincy College and graduating from the Jesuit Loyola Strict School of Medicine, he did an externship at St. Mary's Mission Hospital in Zululand, Natal Province, South Africa. He returned to the US and began a general oncology training program at the University of Chicago, which was one of only 7 comprehensive cancer centers in the US at the time. After 8 years in clinical practice, Dr. McGee came to OSF Healthcare to begin a ministry oncology program, which included developing cancer treatment facilities at OSF St. Francis in Peoria, OSF St. Anthony in Rockford, and the Community Cancer Center in Bloomington Normal. Dr. McGee has served on numerous community boards and was chairman of the State of Illinois Board of Health from 1993 to 2003. He completed a master's degree in healthcare management from the Harvard School of Public Health in 2002 and was the student commencement speaker at the Harvard graduation ceremony. Dr. McGee has been a consultant to cancer program development for a variety of institutions around the world, including Hyderabad, India, Red Army Hospital 150 in Luoyang, China, and his current research interest centers on teaching of Curie therapy or brachytherapy to radiation oncology residents on a global basis. And last, but certainly not least, is Rick Kobus. He's an award-winning architect and innovative thinker with over 40 years of extensive knowledge and experience in the planning, design, and implementation of healthcare facilities, academic medical centers, life science, and research enterprises. He has an international reputation for creating healthcare environments that combine technology and humane environments to enhance the patient experience and quality of care while also promoting scientific discovery. Rick is the founding principal of Tsoi Kobus Design and received a Bachelor of Science in Architectural Studies from the University of Illinois and a Master in Architecture from the Harvard Graduate School of Design. At Harvard, he was awarded the Julia Emery Appleton Traveling Fellowship. Rick was named a Fellow of the American Institute of Architects for his advancement of the profession through leadership of a national practice, creating architecture that furthers concepts of translational medicine and science, fostering humane, collaborative medical research and teaching environments. He's a founding member and fellow of the American College of Healthcare Architects, and his accolades include Building Design and Construction's 40 Under 40 list, Who's Who in Healthcare, Architecture and Design, and Healthcare's Design 25 Most Influential People in Healthcare Design. Rick is currently leading the design team working with the Order of St. Francis Healthcare to realize their vision for a new comprehensive cancer center on their main campus. Promoting a collaborative care concept focusing on the holistic themes of wellness and prevention, the 5-story, 190,000 square foot facility will provide interdisciplinary cancer treatment and house telehealth capable exam consult suites, infusion, diagnostic, and treatment modalities, including CT, PET CT, ultrasound, X-ray, and proton therapy. I'm very excited to introduce the team today from Tsoi Kobus. Over to you.
Thank you very much, Patrick. I appreciate it. And thank you, George. Next slide, please. So just a very quick little bit about Tsoi Kobus Design. I say that we focus on the knowledge industry, discovery of new knowledge in our research laboratories, dissemination of knowledge in the centers of higher education, graduate schools, medical schools, etc., application at academic health centers around the world. And we're the global leader in the design of facilities for proton therapy, which is the most advanced means of treating cancer while sparing healthy tissues around tumors in the body. Next slide. Jim, would you like to say a little bit about Order of St. Francis?
Yeah, we've been in business for about 140 years and grown to be 14 hospitals around Illinois. The largest is in Peoria at St. Francis Medical Center. We are the soon to be the largest employer in the city, and we are very actively growing both in terms of treatment capabilities and outreach services to a variety of resources that are digital. And our motto, basically our philosophy, our guiding philosophy is that every patient, every time is to get the care that they need. So regardless of insurability or ability to pay, all of the patients that need care get care. And we will be one of the few proton centers, I think, in the world where ability to pay will not be a factor in determining whether or not the patient gets the treatment. So we're very proud of our mission, and it's a mission that's needed now more than ever. And we're not going to compromise on the quality of care for anyone.
Next
Thanks.
slide, please. So today we're gonna really focus on how computational modeling is advancing both the practice of architectural and building design, and how similar tools are being used in the practice of medicine. As we were designing this new facility with Jim, we really started talking about the use of three-dimensional tools to understand, to communicate, and in Jim's case, to actually apply treatment methodologies to patients. So I thought it was interesting to just really think about how these digital tools are really changing the way in which we're each practicing, our professions. Next slide. We are great promoters of virtual design and construction, of using 3D parametrically enabled tools to enhance design, establishing conditions of satisfaction early, creating methods of involving design assist from contractors and subs. That leads to accelerated delivery and to real-time cost management of the project. That kind of thinking is absolutely crucial when we talk about the proton facilities that we'll share with you a little bit today, an image of which you see in the slide that's on the screen right now. So proton therapy uses a proton particle rather than an X-ray particle to treat the cancer tumor. And the nature of a proton particle is that it has a very high energy peak for a very short period of time. And with great precision, that energy peak can actually be timed to occur in the tumor. So the energy beam enters the body at a low energy state, accelerates rapidly within the tumor to destroy the cancer tissues, and then actually leaves the body in an even lower energy state. And by doing that, you're really able to reduce the impact of this radiation therapy on the patient. However, it requires an extremely high level of precision. The Treatments are measured in microseconds, and the accuracy is in less than millimeters of accuracy to make sure that you've gotten the tumor. So over the years, we've been working with all of the major vendors of proton therapy equipment to develop these facilities. We did the first facility at Mass General Hospital here in Boston, designed about 25 years ago, opened about 22 years ago. And we've continued to evolve the technology with both our clients and the proton vendors. Virtual design and construction tools are absolutely essential to the design of these facilities. Next slide. We're also able to use VDC beyond the construction documents to aid in digital fabrication of key elements of the project, also critical in proton therapy facilities and in many of the imaging and other treatment modalities we'll talk about. It's also a great tool for creating a digital twin of the building so that in terms of facility operations, maintenance, and actually also the use and maintenance of the proton therapy equipment, the digital twin becomes a really important feature of our work. Next slide. You know, you all are in architectural school, you'll know and actually have advanced many of the tools that I'll be talking about. But we still start with simple site plan analysis, you know, to really understand the site. In this case, a new site adjacent to the main campus at OSF Peoria. It is a main connection to the campus. It's an extension of a new street, north to south, Missouri Street, and it borders a major arterial axis in Peoria called Glen Oak Avenue, the diagonal street at the bottom of the site plan. Next slide. We use physical modeling tools. Even though we're doing a lot in 3D computational models, we continue to use physical models. So a simple tool like this helped us to make a key decision about siting the ambulatory building in blue. The cancer center is a smaller building, low scale building in white, and then a new parking garage. And as we were discussing this with our client, next slide, a simple move of a styrofoam block helped us to understand that there's actually a better way to think about siting these buildings and actually also using these two new buildings to frame a new garden, which became the focal point of a healthy environment for the treatment and for the promotion of a healthy lifestyle related to cancer. Next slide. Exterior modeling tools such as these, you know, the simple block models that you see on the left helped us to understand the basic massing of the building as it relates to the new parking garage and the site of the new ambulatory building in the foreground. But it also helped us to think about, you know, the building stepped in on the south side. We didn't really like that massing in particular. And we took advantage of it to actually use our computer models, our computational models, to look at solar glare, heat gain, et cetera, and used and developed this canopy that really acts to provide solar shading at the south edge of the building. Next slide. And those same digital tools helped us to evaluate the east and west solar glare and heat gain on the building, and helped us to develop this pattern of exterior fins that we're able to demonstrate to the client were actually tremendously effective at reducing both glare and heat gain within the facilities. Next slide. Those same tools are richly embedded with data like these details that allow us to convey quickly and efficiently, not just to our team, but to the design and construction team, what we're actually building the building of, what the elements are, what the costs will be. And so this is part of the digital process of communication that we're using to design and build these buildings today. Next slide. Moving to the interior of the building, one of the key things that we recognized early on was the fact that we had this garden opportunity at the lower level. One of the negative things about radiation therapy departments very often is that they tend to be on the bottom level of the building because everything about them is heavy, which means that very often they don't have natural light. By taking advantage of this garden opportunity, we were able to place the main waiting areas and some of the clinical exam spaces for radiation therapy on the garden, with infusion therapy on the second floor overlooking these garden environments. So that became a key theme of the design of this building. This was a very early section in the design of the building. Next slide. We developed that further using these diagrams to really think about how the lobby works, how we enhance that view corridor while also enhancing wayfinding, and how we develop an inside and outside theme that connects the garden directly to the interior spaces of the building. Next slide. And these simple models that we developed again early on helped us to understand the three-dimensional characteristics of the space, how we would connect the upper and lower floor, and in the next slide, how that visual connection to the garden could be enhanced more. So one of the key decisions that we made with this model is that our opening in the floor just simply was not wide enough. And we needed to actually create an opening larger to make sure that the garden truly was the major impact that you saw upon entering the building. And we further developed these models through design tools to actually come up with the final renderings for the lobbies. So these same views, but now developed fully embedded with materials, details, lighting, etc., to really give our client a clear image of the building that they'll be occupying. Next slide. And then the view to the all-important garden that you can see. Next slide. Even something as critical as the bridge. This was an early model that our structural engineer gave us to tell us what the key structural elements of the bridge could be. And we used these to develop further modeling, next slide, to show how that bridge would connect the cancer center to the parking garage on the right. Next slide. Again, embedding these details into the model so that we have parametric data to inform the construction of the model and help our contractor to understand what the cost of this building of the bridge that we're designing. Next slide. And then really understanding from an internal perspective, how does this bridge work as the major connecting spine between parking that most of the patients will use and their main clinical destinations. Next slide. And finally, completing the design of the bridge to fit seamlessly with the design of the new parking garage and the cancer center. Next slide. So you can start to see how these 3D tools are informing the design of the building. But when we got into the design of Jim's department in particular, we upped the ante quite a bit because we're dealing with a lot of high-tech equipment that has very specific demands. In this case, we're looking at using what's referred to as a ceiling-mounted cone beam CT ring to provide instantaneous imaging while in the midst of a radiation therapy treatment. Next slide. Another application using an arm-mounted cone beam CT device, again, giving the doctors the ability to image the tumor immediately before treatment and sometimes immediately after treatment for dose verification. Next slide. And even more recently, a nozzle-mounted cone beam CT. This is the case of the Varian ProBeam equipment that we're actually installing at OSF that allows the CT to be done essentially real time with the proton therapy treatment. Next slide. We're also looking at developing new technologies like this CT on rails that will be used in one of the key spaces that Jim has developed, an HDR brachytherapy. So HDR is high dose radiation brachytherapy. I'll let Jim describe that to you. But the CT ring allows Jim and his team to image the tumor just before treatment and immediately after treatment. Next slide. And that all comes together in this department that we developed with Jim to combine the cyclotron for proton therapy, the gantry that positions the patient, CT simulation for imaging along with MRI for imaging, the HDR surgery suite, a new technology, HDR, converting to a new variant technology called Ethos. I'll let Jim describe that to you. And then all of the supporting spaces that make this work together. There's a lot of technology being packed into a relatively small area. And this is where VDC really pays off from our perspective. Jim, would you care to comment on the care here?
So when we started out, the comment was made by the administrators, well, we'll have a floor for radiation treatments, and then above that, we'll have a floor for diagnostic radiology services. But the problem has always been that we get very beautiful pictures, very elaborate images. And so we know where the cancer is, we have a lot of detail, but then when we go to treat patients, we lose all of that. And we're not using or haven't been using a lot of that detail to get treatments aligned and set up perfectly. And in different ways that harms us. Traditionally, proton centers were among the worst because of the size of the gantry rotating around the patient, it was hard to do any imaging right on the table. While that was standard in standard radiation departments with standard linear accelerators. So that was a mismatch. We also had the problem in doing the high dose rate brachytherapy or implant radiation, where we're actually going in the operating room and putting needles or applicators into the patient to allow a very intense and miniaturized radiation source to move on a cable through those applicators and needles to really paint an ideal dose of radiation. We were doing 11 steps, 11 different places that the patient had to be to deliver that one dose of treatment. So there, a lot of great things. So we just said to Tsoi Kobus, you know, we need to just integrate the imaging and the therapy so that we can take great advantage of the imaging to make the therapy that much better. So getting the cone beam CT mounted on the gantry is a big step in that direction. But then the patients treated right about where you see number 2. Well, number 3 is a very good quality dual energy CT scanner. And our concept was to put the patient onto the treatment machine on a gurney or a tabletop that could be rolled seamlessly into position 3 for a diagnostic quality image when that was necessary. For example, in replanning, we don't have to start all over again, setting the patient up after taking them down from one setup and so forth. And if that CT scanner were upper floor, that wouldn't be possible, obviously. Same applies to number 4, which is a very high quality MRI scanner, 3 Tesla. There we can move the patient again seamlessly between different areas. And here, a lot of times that would be right after a proton treatment to see what the effect on the brain was, for example. But also from our operating room, number 5, which is set up to put applicators in place that we can image in the room with a dual energy CT on rails, like Rick was talking about. That's shown mounted at the back of room labeled 5. And that's a new technology in an operating room for us, especially for brachytherapy. But some patients also require an MRI. So we want to seamlessly move the patient on MRI compatible tables and anesthesia equipment into room 4 to get an MRI while they're still asleep, if that's advantageous. And then we'd be in a great position to reduce the number of stops for that patient from 11 to basically 2. And then we have room number 6, where we can move the radiation source machine from room 5 in the operating setting to room 6 to do that as an outpatient treatment. And while we're there, that room is being shielded for that type of an afterloader. We are also putting in a linear accelerator for X-ray treatments that's going to be equipped with artificial intelligence. And that will allow rapid replanning and rapid treatment of patients. If their tumor is changing position each day, that'll allow us in 5 or 10 minutes to replan everything and treat again without moving the patient off the table, without just setting them up and saying, okay, this is not right. We're going to change everything, do quality assurance, and get it done and get the patient treated. So key factors here are just integrating all this with number 7, which is the ability to do on-site anesthesia in a full manner. And then not to be missed is the fact that this is fully integrated by a tunnel with our hospitals, our children's hospital and our adult hospital. Most proton centers are bulky, they stand by themselves, they're isolated from the rest of the medical world. Here, this is as integrated as it gets in terms of all of our services. So we really thank Tsoi Kobus for working to get this all put together. Next. So our surgeons started doing some work with our innovation lab at Jump Trading Simulation Education Center. And they started to model congenital heart disease patients for a children's hospital. And they started to model tumors in the upper abdomen in children, where they would print with a 3D printer those configurations of either the bad heart or the tumor. And they would actually then use virtual reality goggles and a mannequin and practice doing the operation on the 3D printed model and learn what they were going to encounter, what the problems were going to be before getting in the operating room and being surprised by things that they hadn't anticipated and looking just at plain two-dimensional images. We had the same issue with our implant radiation patients. And so we started then doing 3D printings of lots of different things for practicing, because we were always, if we did 2 implants on the same patient, the second one was always better. So we said, let's just do the first one virtually. So we would print things like the cervix cancer here, putting graphite in it to make it appear like a tumor does on MRI imaging. We'd 3D print normal tissue anatomy like the pubic bone bladder, a loop of bowel at the top. And then on the end, we would have a model that we could actually physically implant with radiotherapy. And here you're seeing a patient with cervical cancer that's been modeled, and you see the vaginal canal and the anal opening. Next. So these can have ultrasound and so forth through the anal opening. Here's a practice going on. We're going to be treating a uterine cancer without surgery, just radiation. And we're working with an applicator that we had no experience with. It was kind of complex to work with and assemble. And trying to do that in the OR for the first time on a real patient is very nerve-wracking and sometimes doesn't go well. So we practiced that and practiced that and practiced that on the mannequin. Next. And as a result of that, had a perfect implant the first time out of the box. And here, what you're seeing on the left, the 3 bright spots in the middle of the little orange cloud there, those are just the metal parts of the applicator. And the orange is the dose distribution that we were able to get. And on the right side, you see the orange cloud of the orange cloud is basically the tumor area, and the red around that's the ideal dose zone. So we perfectly matched the ideal dose to this tumor using this applicator, and all of that could only happen because we were familiar with it from predetermined practice. Next. So going on then, we want to extend these use of these virtual tools into developing treatments that not only do we anticipate doing better, but then we can actually physically do better in many different ways for both external radiation and implant radiations. In my training, I was taught in France to do molds, vaginal molds for cervical cancer, to make a custom applicator for patients because everybody's very different. Their tumors are very different. And so for a very long time, we were doing that with alginate paste, which is what the dentists use for molds, and going through this kind of tedious process of taking the patient to the OR and making the mold, and then taking the mold to the dental lab and having it made up, checking this, all of that, taking a week or 2 to get this done. And so it was very limiting. Next. So this was the type of situation we were in. This poor gentleman had a big tumor excision from the back of his head. We were in this position trying to treat with implant radiation, and these catheters will carry the radiation source over the tumor into this device, this applicator, which on the right you can see is hooked up to a machine that'll load the radiation source and sequence through those 5 channels. But this is all, he has to come in, get the alginate impression, and then we rely on somebody to make it. Not many people can do it, et cetera, et cetera. And it's a very tedious and sometimes imperfect process. Next. So the obvious solution then is to just do the CT that we do for treatment planning and not burden the patient any further, but to create in the treatment planning system what we want to do. And then step 2 is to create either a bolus, which is a material to put on the tumor to get the ideal shape and so forth for the radiation catheters, or it's just something that you put on the skin to raise the dose to the patient's surface tumor. Whatever you want to do, these are just materials that we need, but they have to be exactly right for that patient and their tumor. So after we get that verified, we send this off to the company Adaptive in Halifax, and they work with our treatment plan to actually figure out just exactly what we need in terms of either an applicator or something to put on the patient to trick the radiation into a perfect arrangement of beams. And then they send us back the necessary algorithm to load into our printers and 3D print the materials that are ideal for that patient. Next. So that same patient, if he were treated with this type of a CT-based digital transformation into this space, would have had a much more elegant setup like this, which we would have had a lot easier time positioning each day. And we would have had a great deal of comfort that we were right on target exactly, rather than thinking, yeah, that looks pretty good. We'd actually be absolutely on target and patient would be absolutely secure. Next. There are some types of cancers that are seemingly very simple, but can be very complex. There's nothing worse than seeing a patient having their nose amputated by a overly aggressive surgeon. And these patients can do very well with radiation treatment for skin cancers and nasal tumors, but it is very tricky, both with implant radiation and external beam treatment and particle treatment, because of all the changing contours, the air cavities, the slopes, the this, that, and the others, the proximity of the eyes. Lots of things come into play here. All we're showing here is that we created on the left an ideal adapter for this patient's nose that, when positioned on the nose, as shown on the right, allowed for those channels to be in perfect position for the radiation source to move through there, and again, paint an ideal dose that takes into account all those variations. That's a level of sophistication we can't do by hand without the help of these 3D tools. Next. This is a patient that would be treated with a mold in the vagina, but traditionally those molds were only intracavitary, meaning that where you could put the radiation source was just in the vagina. Sometimes a tube up into the uterus if the patient still had their uterus. But in cancers such as cancer of the vagina or cancers of the cervix, where the cervix was still present, but the tumor was growing outside the cervix, intracavitary radiation, putting a source in the vagina, just doesn't reach that area. So right now we're putting a lot of needles in from all the way down the perineum, all the way up. Lots of pain, lots of discomfort, lots of uncertainty, lots of potential for hemorrhage. Most doctors won't even do that type of a procedure. We do them a lot, but we're very interested in totally moving now to this type of an applicator that's 3D printed, that allows the gel in the vagina, not alginate, but just gel put in for diagnostic imaging, to show us the vaginal cavity and to predetermine how a few needles passing internally can cover the area that needs to be treated with the needle component of this therapy. This is really a great advancement for us in terms of simplicity and elegance, safety, reduced pain. Just a remarkable improvement this will be. Next. And there are just, simple things, again, like cancers around the nose that can be treated with external beam radiation. But the surfaces are sloping so much, there's so many air cavities. We want to fill in all those air cavities, want the external radiation dose to be uniform. And now we don't have to bother the patient with coming in, having a painful thing done to try to figure it out or whatever. But we can actually 3D print from a CT an applicator. So the patient just shows up, lies down. We put this on and in their nose, and the treatment is just right from the get-go. Next. And sometimes with situations like post-mastectomy radiation to the chest wall, we need to increase the dose to the skin to get a nice uniform therapy. And again, we have trouble with that. Right now, they put a wet towel on the patient's chest. That's really sophisticated. So we do a 3D print of what you see there in the lower right, which is a custom bolus material that's then applied to all these creases and folds of the patient to, again, allow a very uniform radiation dose that's making sure we don't underdose or overdose various areas. Next. Some of these materials that we can put on the patient's surface not only raise the dose to the skin, but prevent particles from going too deep in the body. And so protons, electrons, or particles that have a limited range, protons in particular, come in and, as Rick said, give up a little dose till they get to the end of their range, and then they, through the Bragg peak effect, give up their remaining energy. Well, in protons, we want that dose to fall at the back of the tumor. We don't want it to go on through other structures. So with the combination of treatment planning and 3D printing, we can print a bolus which corrects for us how deeply these radiations are going to travel and spare a lot of normal tissue. We can show that on the next slide. This is a child with a rhabdomyosarcoma. And you look on the right, and this is what we've traditionally done, is lay some, it's called superflab on the skin to raise the dose to the skin. Well, that's great. Now we're getting dose all the way up to the surface of the tumor, but we're giving a lot of dose that's of no value to that kidney. With a custom bolus, you can see we can pull the dose out of that kidney while still giving the surface dose that we want, a much better situation. And this is a common problem in X-ray treatment, cancers around the mastoid and the ear and so forth. We've tried to make a uniform dose distribution traditionally with various things that we try to put on the patient's ear and so forth, as shown on the left. And that's not going to give a very uniform dose. That's not going to be a good outcome. But on the right, with 3D printing, we can make an applicator that fits the ear well, that fits to the skin well, doesn't have air gaps that lead to undertreatment, doesn't have hot spots from transmission through air that we didn't anticipate. So go to the next slide. So that kind of a thing can be arranged just by, again, taking a CT picture of the patient, giving a 3D print to the type of applicator that we need to smooth that dose out. And here you just see the reality of that being applied to the patient for their treatment. Very straightforward from the patient's point of view, because nobody had to do anything weird to them to get the material information to make this. We just did this all virtually, and the patient really gets a vastly better treatment than what we were doing before. Next slide. Let you.
Hi, good afternoon. We're going to shift gears a little bit here. We understand from Professor Mann that one of your research and design studios will focus on a project involving telehealth. And we wanted to share a few ideas we've been working on with Dr. McGee. As you probably know, the pandemic accelerated the adaptation of telehealth in many hospitals, and telehealth has expanded access to care, especially during the pandemic. Through telehealth, they were able to reduce the risk of exposure to COVID-19 for patients and for staff. However, telehealth with its limited tools could not really be adapted for all patients. And although physicians and patients are connected with video and audio, their interaction is limited. Next, please. When we first imagined a telehealth capable exam room, we considered the importance of all participants to be at eye level with one another to facilitate communication. And we designed a flexible space where patients' electronic records could be easily shared, where family members could participate remotely. And this idea evolved quickly, and through the work with OSF Simulation Lab, Dr. McGee and others explored ideas about telepresence. So next, please. So telepresence is a different form of telehealth. And many years ago, you've probably seen the robotics that facilitated greater interaction between clinicians and patients by bringing a physician through a robot located remotely to the patient. And with Dr. McGee, we are taking telepresence another step forward. And Dr. McGee, would you like to discuss the technology currently being developed for the OSF Cancer Center?
So we've found that the traditional things that were deployed for telemedicine last March were very limited in terms of our ability as specialty consultants to really feel that we had engaged the patient and gotten to know the patient. And our feedback from the patients was similar in that they didn't feel like they had really gotten too much out of the consultation many times when we're dealing with, we're new to them, they're new to us, and it's a complex problem. So we wanted to be able to, as Ann said, share images with them. We wanted to have their medical record easily at hand. And some of the things were just very straightforward. One of which was starting out using larger monitors for the patients to see us. Maybe we could go to the next slide. In the lower left there, you see that the consultant is being presented on a vertically oriented large monitor and has a much more significant presence than if he were on a regular standard computer desktop computer or laptop computer. So that's a real start. The sound system has to be good so that nobody's shouting, nobody's having trouble being heard. The specialist sometimes, if they're listening to heart tones and lung tones, will wear a high definition headset and with a digital stethoscope on the other end that's being manned by either the patient's primary care physician, an APN, or a nurse. And that really helps us to get a sense that we're with the patient, and also for the patient to have more confidence that their needs are really being expressed. So patient at the same level as the consultant, but we also came to the finding that having these larger monitors was important on the consultant's side in order to feel that they had connected to the patient and they could really see the patient. You know, they're sometimes asking the patient to do various parts of a neurological examination and move their hands and so forth in a certain way, move their eyes and such. And so this larger screen monitor on our end as a consultant is equally important, I think, is for the patient to feel that they're engaged with us. So these factors have all driven quite a bit in terms of our design for the center. This is something that Ann was charged with helping us to put together. In reimagining how we would do consultations with patients, we thought that this environment going forward was going to be one where we'd probably have the patient with us, but we might not have all the specialty consultants we need at one time for a multidisciplinary clinic. And we'd have family members that were with the patient. We'd also have equally interested family members who were not with the patient. And we wanted to have the flexibility to deal with all of that. So we had the concept of, on the upper right, you see there's basically a room where patient and family could interact with the patient's images, have the local on-site clinicians explain things, but also could have a visit with a clinician who's not present, who's critical to the decision-making. And if we need to examine the patient, we can just take the patient by themselves, leaving everyone else in that conference room over into an examination area where a proper exam can be done, again with the consulting doctors as necessary in telepresence. So, Ann?
Next, please. So you can see it's a very interesting problem to solve from a design point of view. And here for OSF, we're looking at, we've gone from the simulation lab into the actual exam room and finding a solution that is both user-friendly and not intimidating to the patient. It's an interesting design to think about. We know telehealth will continue to be part of the patient experience and an important part of delivery of care, especially for rural communities. But we're excited by the idea of telepresence because it enables greater interaction and feedback for faster diagnosis and treatment for critically care patients. So good luck on your studio. Be fun to see what kinds of things you come together with. This is a quote from Steve Jobs, obviously applied to Apple, but the idea that the broader one's understanding of the human experience, the better design we will have. And we think that it can also be said about the architect's role in the planning and design of healthcare facilities. Next, please. Our projects typically begin with visioning workshops, and our healthcare clients and frequently with patients. And among the many aspirational ideas we hear, there are three that are universal. The first is that the architecture should convey a sense of hope. And second, that all constituents have their voices heard. And the third is that the patient experience is defined by every encounter, from arrival to departure. Next, please. These are examples of visioning tools that we use in the very early phases of a project. And while working in plan, we employ 3D tools to explore and communicate spatial relationships, design possibilities, and the human experience. The image in the lower right is from Revit with a collage overlay. It's a very simple and quick way to visualize an environment, materials, and to convey the human interaction within the space. Next, please. Much later in the project, we develop fully rendered images of the architecture so that we understand what the experience feels like and not just how it looks. Next, please. We imagine the patient's journey from multiple perspectives in order to optimize the performance of the spaces and to improve the overall patient experience. Next, please. And just to follow up on Rick's earlier comments, form giving, especially to interiors, is inspired by many things. And for the public spaces at OSF, the design was based on patterns in nature and the idea of connecting the interior space to the garden. I think the design of both the garden and the interior evolved over time and was a collaborative process using 3D programs to find the harmony between interior and exterior. Next, please. Another form of visualization in healthcare is the use of virtual reality as a coping mechanism for people with serious illness. And often there are spaces for reflection and meditation included in cancer centers because they're such an important part of the healing process. And Dr. McGee, maybe you would like to describe the research that's being currently done with cancer patients.
Yeah, so we have an ongoing study that looks at reducing depression and improving patients' health markers and outcomes based on an ongoing daily dose of positive affect. So that can be achieved in a variety of ways by encouraging exercise, by encouraging better nutrition, not giving in to just eating junk food when you get cancer and sitting on the couch. But a lot of that does go back then to the patient having a good sense of things about themselves and their potential outcome so that they are able to realistically look at doing some exercise, doing some healthier eating. And that really starts with them getting their mind right, getting an ability to deal with the stress that they're under. And we think that there are some ways with virtual reality to try to do that, and that'll be built into our meditation room, but it'll also be something that will be built into trying to help patients understand what's going to be happening when they go in for their radiation treatment and things like that, so that they don't have to live through the stress initially in the real world, but they can see what this is going to be and do that in the virtual world. And then hopefully that makes going into the real world better. And as they gain confidence, hopefully they then are more motivated to be able to do the healthy activities that will sustain their health over their lifetime. Next.
So at OSF, planning and design brought us to a tangible idea related to wellness and prevention in addition to treatment. And Dr. McGee felt strongly about the influence of nutrition in cancer care, and ideas developed into a wellness and prevention program, including a teaching kitchen with an adjoining kitchen garden in a space that's directly adjacent to radiation oncology. And through 3D visualization, we developed and designed and actualized the connections between treatment and wellness. And there's so much we could say about how this all came about and what it means to patient, the outcome for patients being treated. But Dr. McGee, maybe you would like to say a little more about the vision for the new cancer center.
The vision for the Cancer Center is that it's the hub for the cancer care across Illinois in our 15 different hospital facilities and our innumerable clinics and home sites, as well as in a burgeoning digital health outreach to provide patients with not necessarily medical care, but with services that relate to their health. And so my notion with this was not to build a high-tech proton center and be criticized because, well, how much does that really do to improve health? But to use the proton center as the genesis of a real interest in improving the health of the people in Illinois who have some of the worst numbers in terms of basic health in anywhere in the nation. And that starts with the basics and things that we take for granted. People don't always know where food comes from. They may find it impossible to conceive of cooking even a simple meal at home, let alone a healthy meal at home. And then they have no idea that they feel so lousy because they never do any form of basic exercise. So we're not asking people to buy a home gym setup, some stretching bands, maybe a lightweight. We're not asking them to become French cuisiniers, but we're hoping that they'll really be able to see that the basics of life, the simplicity of the basics of life, really lead to an elegance in treatment and care, and that whole notion of a healthier being extends into their survivorship and starts to affect their families in a way that helps them to hopefully prevent getting cancer in the first place. So it's soup to nuts, cradle to grave, start to finish, alpha to omega, in terms of trying to use this cancer center to really promote wellness in downstate Illinois, and as a model to not just be a technical treatment center, but a center for people who, as was said, from start to finish, are getting something good for their health along the way and a positive experience. My own youngest daughter had cancer, serious type, had to have proton therapy, and I went with her when she went for her first visit to a proton facility that was designed by Tsoi Kobus, and we had huge anxieties going in. But when we encountered the architectural design, just knew from the beginning, as soon as we walked in the door, that this was going to be okay. So I would like the students to never forget how important all of this is in terms of setting the tone for how people live and actually how practitioners choose to work within those centers. It's very hard to go into a great center like this and think you're going to do second-rate work.
Rick, I think you're on mute.
Sorry, I'm on mute. I want to thank you, Jim, and you, Ann, for a wonderful presentation. I think you can all see how these 3D computational tools are influencing both of our practices and how they come together to create a really extraordinary environment for very high technology cancer care in the plains of Illinois. Takes me back to my days at the University of Illinois, only a few hours away from Peoria. So it's great to have worked on this project with Jim and with Ann, and we'd love to take any questions that you have.
I think that was a wonderful presentation. And to all of us, the fact that you presented with other disciplines that are involved strengthens the importance of architects working collaboratively with other disciplines. And nowhere is that more important than in the medical field. So I want to hold my comments. I'd like the audience to come on board. If you could show your cameras on, I think that would be helpful. So any questions from the audience or comments?
I have a quick question about the exterior garden. On that original section you showed, you had the one side lowered. I'm wondering if that was something that you did intentionally, or if that was built onto the site as is, just with the elevation change, or if you have specifically dug that out to create that lowered space.
Truthfully, it was a combination of both. The natural site actually did deflect down or grade down, not quite as far as we had to go down to get to the lower level. The proton therapy equipment and the photon therapy equipment also all require pretty high floor-to-floor height, 20 plus feet. So we had to excavate down a bit further than was the natural topography. But the idea really sprung from that natural topography.
All right, thank you very much.
I have a question about the provider's journey in the architecture. You really focused a lot on how patients interact with the building and how it kind of alleviates that stress and anxiety about going to see a doctor for an appointment. I was just wondering how you approached the provider and doctor side of the design.
Well, I think you see in the exam room consultation that is a multidisciplinary floor. It's a floor where multidisciplinary clinics will be held. So we brought the doctors who would be involved in those clinics in and said, okay, this is a sketch of what we're thinking about, and how would you change this to be better? And that led to wholesale changes, and everyone agreed that we needed suites like the one we just showed, with the exam room off to the side of a small conference room. We could use those individually or together. And we have other conference rooms and things where a large number of doctors could talk with families and show all the imaging and so forth. So really it was a matter that, we just had a little sketch for somebody to work from, and then brought the leaders, I guess you'd say, of the various tumor boards in and let them give commentary about how they would think this would work. Because we've all had experience with multidisciplinary clinics, and we've always made catch as catch can. Usually I'd wind up going in and sitting on a exam table with a patient on a chair, and all this stuff just was ragtag. So we tried to solve all those problems, and at the same time have separate space where the clinicians could go and do dictation notes and things like that. So yeah, but you just bring them in and you let them participate, but they were glad to do it.
Wonderful, thank you so much.
It's probably another hour-long presentation to talk about, how we develop the staff experience. And it's a parallel track with the patient experience. We're looking at it simultaneously during the design process. I think from a design point of view, we do very rapid prototyping for the staff. And so we're able to use our three-dimensional tools, but we also build a physical space. And we have something that we typically do, we call it Cardboard City. You've probably seen, these big full-scale mock-ups. And we did that with OSF. It was really fun. And we built the most important, significant, repetitive environments. And it's amazing what happens in those interactions, because you physically see the space. You are able to be in the space with the real equipment. And it's the way that we make sure that all of the staff related issues are addressed. And then equally, there's the side of how you deal with kind of the emotional issues around, what the staff needs to support their own journey. So it's great.
Wonderful. Thank you
Yeah.
so much. This was a lovely presentation.
Thank you.
George,
any-
I have a comment.
Yes, Ron Scott.
Congratulations to the presentation team, an excellent presentation. And I presume this facility is now in construction or soon to be. And I see it having the potential of being a world-class referral center, with Peoria being between, as I remember, Chicago and St. Louis and Fort Wayne to the west and Omaha, Fort Wayne to the east and Omaha to the west. How far do you think you're going to reach out in referral patterns?
It depends on service. We think that our services such as better health, better survivorship, we think that will go broadly from coast to coast in the state of Illinois, so from Indiana to Iowa. We think that we will get referrals for, we're going to build a flash mode into the proton, which will be a amazing tool in the future. We think for flash proton therapy, we'll probably receive referrals from many states. And I think that for standard proton therapy, we probably would be receiving from Iowa and Indiana, neither which state has proton beam therapy. There is a proton facility in Chicago and one in St. Louis, but it's a lot easier for folks like me who are country folk to come to Peoria, Illinois than to go to Chicago or St. Louis. So the reality is we want to make people comfortable, but we want them to come. They'll come one time to look, but we're counting on this cancer center to make them come and say, "Well, that was very special. That was some." We've recently had a person that we're trying to recruit who's very familiar with all the centers in the Midwest, and we've been so far pretty successful in recruiting a top talent. And because he said, this cancer center has stuff that nobody in Chicago has done. So
Well,
and that's
congratulations.
all that integration,
Well, my parents had cancer operations 3 days apart by the same surgeon. My mother went in for kidney removal, and my dad that night hemorrhaged, and I took him up to the hospital. And as they recovered, he kept running down to her room. Finally, I was called in by the hospital administrator as to what I was going to do about my father. He was 83, my mother was 78. And so I said to the administrator, my father thinks NYU is the Empire State Building and he's King Kong. And there was no way he's going to buckle to you. So the administrator got it, and they put them in as roommates. What clinched it is when I said, he's 83. Are you worried about my mother getting pregnant? She's not Sarah in the Bible. And so it was just something to behold. And I got very close to them. He lived 5 years and she lived 10 years after that. It was an incredible part of my life. And I was so glad I could be there as much as possible. It's quite a commute from Texas, but I'm very sensitive to this subject. But also what you've done, I look at the health field like you climb a mountain. And boy, you get to the top of the mountain and then you see more mountains that you want to climb. And the more you're in it, the more you want to do, but there comes a time when you can't do so many things. And this is what I throw out to the students. It's intoxicating, where I had this vision of so many people having cancer on earth and these centers and what could be done to alleviate medically and emotionally. So it was a wonderful, inspiring presentation. I can still get inspired, and it's just looking at the students who are thinking about things is energizing. So with that, do we have any questions about anything? There are a few people who are doing this for extra credit. If there are any questions, I can stick around afterwards. And if not, this was just one of the best presentations. It just hit home on a lot of levels to me. So I told you about my parents. That was something else. You should have seen the expression on that hospital administrator's face when I likened my father to King Kong. And so if we have just a few more things before we close, Catherine, do you want to flash up next week's lecture? And we have Tushar Gupta from EYP, and he's got a team from the hospital. Oh gosh, I'm having difficulty seeing those names. So
It's Houston Methodist Hospital, I believe,
yeah.
George.
Is that Sid
Sanders.
Sid Sanders?
He's the head of facilities there. Used to be University of Texas head of facilities.
Thank you. Haywalk Park and Tushar Gupta, just one outstanding alumni, and I can't make out the other name.
Andrew Albers is the vice president of landscape architecture of OJB.
Yeah, well, you got good eyesight, Patrick. Thanks, and for the help. And for those of you who are interested in any lecture, you simply can click on this and go right to Zoom. And if anybody needs the continuing education form, you can email me or send me a chat. So was there a hand up, Casey? Did you have a hand up for a question? Oh, Joan, yeah, I saw it. Joan, please go ahead. I don't want to cut you off.
I have to unmute first. I just wanted to make the comment to Dr. McGee, my great appreciation for his understanding of the holistic approach to health, in engaging the entire body's nutrition and exercise and that hope factor. It's just because the beautiful architecture that you people came together with is soaring hope, as I viewed it. So I want to thank you for your foresight, your vision, and your ability to put this into practice. And I trust it will be a model that will actually go far and wide. Thanks.
Thank you.
Yeah, I got one on the class chat, two of them, one from Noah Smith. It was cool to hear them affirm the importance of our design within telehealth and healthcare. Another comment from Valerie Nieto. It was an interesting presentation. It was nice to see how they went from point A to point B. Thank you. So the students are now going to spring break, and I want to wish them a healthy and safe spring break. And I'll see you back Monday at 8. And to our guests, Dr. McGee and Ann Garrity and Rick Kobus, thank you so much for taking the time and doing this. We really appreciate this. And to Ron Skaggs, thank you for the support from you and Joe Sprague. So with that, I'm going to put a reaction. I saw Patrick did. I can't have him beat me here. I got a hand clap, and then I got a thumbs up. So let's give him
Can't we just clap this way?
the old-fashioned way, right? I'll stay on for a minute if anybody has a question about the content or anything. But thank you again. It was wonderful.
Thank you, George. Good to see you. Thank you, Ron and Jim and Ann. Thank you both very much for all the work you put into this.